Bismillahirrahmanirrahim. Good morning, everyone. Today's lecture is about guidelines for gynecological ultrasound, and I am Professor Dr. Syed Ahmed Gilani. There are a few important steps for sonographic evaluation of uterus, cervix, and adnexa, which means the ovaries and the surrounding structures. The things which we have to see are uterus, cervix, and adnexa. In uterus and cervix, we see the size, shape, position, and echogenicity, especially of the endometrium, myometrium, and cervical canal. In adnexa, we look for the size of the ovaries, their shape, their position, and echogenicity. We can have a uterus which is larger in size as compared to the normal measurements, and we can have a small uterus which is called infantile uterus. In shapes, we can have different types of shapes of the uterus. We can have a normal uterus which is abnormal in shape. It can be abnormal in position like retroflexed or retroverted uterus. We look for the echogenicity of the myometrium, either it is normal as compared to the cervix and the outer layer. Then we look for the echogenicity of the cervical canal, the competence of the cervical canal, its length, and how its walls appear. Similarly, for ovaries, we look for size or volume of the ovaries. Then we see the shape. Usually they are oval shape. We can look for their position and echogenicity. The echogenicity varies depending upon the stage of the menstrual cycle because of the absence or presence of follicles. We can also find some anomalies and pathologies in uterus, cervix, and adnexa, which are related to the location and relationships, size, borders, echotexture, and vasculature. In transabdominal ultrasound, full bladder is required because it provides an acoustic window into the pelvis. There are some limitations for transabdominal ultrasound, which includes the obesity, inadequate bladder filling, abdominal scarring, recent surgery limiting access, retroverted or retroflexed uterus, fibroids, or we can have some air bubbles. Intestinal gases can also disturb, but if the urinary bladder is properly filled, we can overcome gases in the intestines. And pressure technique is another important thing. So these are the limitations for transabdominal scan, for which you can see here we have got the anterior abdominal wall. This is the anterior wall of the urinary bladder. All of this is urinary bladder, and anechoic area is the urine inside, which is anechoic. This is the posterior wall here and the lateral walls of the urinary bladder. And below that, which we call posterior, as the transducer is here, you can see the transducer is at the anterior abdominal wall. So beyond the posterior wall is the endometrium along with the uterus. Here we can see the cut section. This is the magnified view. Here you can see the 5-line appearance of the endometrium. Then comes transvaginal ultrasound. It does not require full bladder, but we prefer to have transabdominal scan with full bladder. Then we ask the patient to empty her bladder, and then we can perform transvaginal ultrasound. Why we need transabdominal scan before transvaginal ultrasound? The reason is that we need to have a global view, which is possible by transabdominal scan. Then the high resolution scanning with more magnification is seen in the transvaginal scan because there is better identification of early and ectopic pregnancies. The follicular size, small masses, abnormal fallopian tubes, endometrial thickness can easily be assessed because the transducer used is of higher frequency. And this is the transducer which is used in transvaginal ultrasound. It has got a shaft, handle, and this is the area which is having the crystals which the shaft enters into the vagina, and then we can have this type of field of view which covers a lot of area on both sides of the pelvis. And here we have an image which will be visible on our monitor of the ultrasound machine. This is endometrium, and then is the myometrium on TVS. So this is the approach, transabdominal approach and transvaginal approach. Comparing both, you can see the urinary bladder which is full with the uterus in cut section. There is early gestational sac inside, and here we have transvaginal which is having improved resolution and the sac is more clearly evident. We can see the inner structures even in the gestational sac, and this is the myometrium. When we talk about the endometrium of the uterus, the first thing which comes to mind is measuring the endometrium. The midline sagittal plane in the widest area of the fundus, all layers of endometrium are included. So there are two important things. We measure the widest area from the fundus. Then we include all the layers of the endometrium. And this measurement depends on phase of the menstrual cycle. This is how we measure. We measure from this end to this end. This is the endometrial myometrial junction. And on the other side again we have the endometrial myometrial junction. Here is the cavity. So on both sides we have endometrium. We will measure from this end to this end, which we call measurement of the or thickness of the endometrium. Here is fluid in the cavity, intracavitary fluid excluding from the measurements. So we will measure this area and we will measure this area. We will exclude the fluid from it so that we will have the measurement of the walls. Then we come to the endometrial appearance and its thickness in different phases. In early proliferative phase, there will be relatively thin echogenic line composed of echogenic basal layer next to the central endometrial interface. It will appear like this. Whereas in late proliferative phase, we will have triple line endometrium. These are the three lines, 1, 2, and 3 lines. So it becomes more hypoechoic with multi-layered or hollow appearance. This is an example in which you can see the triple line appearance. We can say one layer, second layer, and third layer. And it is in the late proliferative phase. On Doppler we can see this is a spiral artery, and we can assess the spiral artery flow on spectral Doppler. In this case, the resistive index is 0.553. Then comes the secretory phase. In secretory phase, we will have thick, uniformly echogenic band at maximum thickness, which is 7 to 16 mm. Endometrial glands become tortuous, filled with glycogen and mucin. Uterine artery has low resistance and pulsatility index. This is the secretory phase. You can see the endometrial appearance is like one hyperechoic area. The endometrial lining is not very clear. So in the secretory phase, when we find a spiral artery, we can have spectral Doppler of it, and you can see the resistive index is indicative of implantation when it is 0.553. So spiral artery flow resistive index is usually around 0.55 here. So the landmark, the cutoff value is 0.5. Thank you very much.